in each of these phases of sleep or stages. So the non-REM parasomnias are the most common parasomnias. Children sleep really deep, and a lot of times this is parents come to me and say, I really can't wake them up. Well, they sleep really deep. Their slow wave sleep is really deep. My very first mentor in sleep medicine used to say, if you pick up a child out of deep sleep in N3 and put them on their feet, they'll start sleepwalking. So that's as it is. So they're very, very common. They have some genetic predisposition. So if the parents had sleepwalking, or the grandparents, or the brother, there is chances that they will also have it. Sleepwalking, sleep talking, night terrors, confusional arousals are very benign. The main thing is that you have to advise the parent in safety measures, and you have to be sure that this is a non-REM parasomnia. So what I mean by non-REM, it occurs early in the night. It occurs usually one time. It can almost be predicted at one time. Like the child goes to bed at 9, by 11 o'clock they start sleepwalking, and then they don't do it anymore at 9. That's very, very typical. If it happens, and we'll talk later about it, if it happens at various times, if it happens many, many times during the night, then it could be a little atypical. Most typically they happen once a night within the first 2 hours of sleep. And sometimes, and there is no injuries. If there is injuries, then we need to explore further. Non-REM parasomnia, the most common in children, most benign, are nightmares. They're very common in younger ages. But we also have a parasomnia called REM sleep behavior disorder. It is extremely rare in children, and when it happens, it is always abnormal, and it is a reason for referral. The REM behavior disorder is manifested as dream enactment. So it's common in older men, in patients with Parkinson's disease. They're dreaming that they're being chased, and then they get out of bed and run into the closet, or they jump out of bed and hide under the bed. If you ask them what happened, they will recall a dream, which is different from sleepwalking, night terrors, and confusional arousals. The child will not recall a dream. When to refer any time that there is an injury. You can see a bruise here. This was a girl who got up and ran in the middle of the night and got a bruise, and she had such a severe obstructive apnea that it wasn't REM behavior disorder, it was just she was confused and got up. Anytime that you suspect REM behavior disorder, anytime that you suspect that there was secondary enuresis, the child was continent and started having enuresis again, and you suspect that it's due to a sleep disorder, and anytime that you suspect that these abnormal behaviors are actually nocturnal seizures. And when could they be nocturnal seizures? When they are stereotypic, when the child repeats the same things over and over, like bicycle, like moving the arms, when there are repetitive events through the night, or there are abnormal postures. Sometimes they would just look like they're having these stonic postures at night. When the timing occurs at different times, not necessarily at the same time, but it can happen at 11 and at 2 and at 5 or any time, and also when they're like really brief. Usually parasomnias could last like up to 10 minutes or 15 minutes in night terrors, but the seizures are usually very brief and repetitive through the night, and it is very important to refer for a sleep study. Obstructive sleep apnea is another reason, and sleep disorder breathing is another sleep disorder. The pathophysiology in children varies, is not always due to the same thing. It can be hypotonia, it could be excessive tissue, tonsillar hypertrophy, muscle weakness. It is many, or a combination of factors. In this study shows that remember I mentioned about the exam, the physical exam, and the history. Well, in this study, it shows the predictive value of the physical exam and the historical features. So if you have a child who has tonsillar hypertrophy, or a child who snores more than 5 nights, these are their positive and negative predictive values. And if you see they're like 60, 67, 65, not really good. So we do not have really something to say, well, yeah, these things are convincing that your child have obstructive sleep apnea. They're usually just 60 positive predictive value or negative predictive value. So this is one of the reasons why we do a sleep studies in children because we have had children with 3+ tonsils who snore, and we have normal sleep study, and we have children with 1+ tonsils and very loud breathing, and we have abnormal sleep study. Very, very low predictive value on this. The highest predictive value that we've had is actually if the parent comes and say, my child stops breathing, and that only has a 79% predictive value. So the diagnostic criteria for obstructive sleep apnea requires 2 things. One is to have symptoms, to have snoring, daytime symptoms, but the child must have abnormal findings in polysomnography. An apnea-hypopnea index of more than 1 for children, or obstructive hypoventilation, which sometimes people forget. So we have children with normal apnea-hypopnea index, but who have CO2 levels of more than 54 for half the night, with loud snoring, paradoxing, symptoms during the day. That child classifies for obstructive sleep apnea. We also use pediatric rules for scoring of events which are missing 2 misbreaths, and this is an epoch of one of our polysomnographies. This is a 1-minute epoch. So you can see on the top the EEG leads, the eye leads, and the respiratory leads. So this is nasal, oral, we have chest and abdomen belts for effort, and we have capnography and oximetry. And we can see that the child is breathing, 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 and normal breathing here, and then suddenly there is a pause that lasted at least 2 breaths and a flattening on the line. That is how we score an obstructive apnea. And you can see that there is still effort on the chest and the abdomen belts. This is how we grade obstructive sleep apnea in children. So anything more than 1 is abnormal. We call it borderline between 1.1 and 2, so it's like very borderline. From 2.1 to 5 mild, moderate up to 9.9, and severe anything more than 10. Now why do I have this little asterisk here? Well, because we are allowed to call in children older than 13 to score as an adult if a 13, 14-year-old has the body habitus of an adult, like if there's a child who's as tall as we are and weighs as much as we are, is 14 years old, well, and has an apnea-hypopnea index of 11, we're not going to classify it the same as a 2-year-old. So that was the Academy of Sleep Medicine gives us that clinical criteria that we can discriminate as clinicians and say, hey, you don't really have severe apnea, but it's mild, so these are options for treatment for mild apnea. The most cases of severe in this published study, as we can see, are in the little ones. So severe is the dark square, so obstructive sleep apnea tends to be more severe in younger. Now, also with the presence of comorbidities like obesity and hypertonia and other symptoms, we can see severe obstructive apnea in older children. So, talking about a little bit about the movement disorders, this is actually the very, very first publication that was made on restless leg syndrome. And this is actually a little bit of a historical treasure because this was written by Dr. Ekman. That's what is called Ekman disease, Ekman disease. And if you see up here is in handwriting the very first pop-up paper. So this was provided to our group by Dr. Ekman's son. This paper was a case series of 5 patients that complained of paresthesias. So this talks about really the importance of case series. Anyone who wants to Google me or put my name in PubMed, you'll see that a lot of my publications are case reports. And don't disregard the case reports. If you see something really interesting and different, publish it. So this is the lesson. Most situations in the history of medicine have started publishing by small case series. This is a drawing of a child. How do they describe restless leg syndrome? Like ants on their legs. So it is very difficult to really understand restless leg syndrome in small children. But if a child is able to verbalize and explain their symptoms, the criteria is quite simple. Urge to move the legs. It occurs mostly during sleep, and it's really alleviated by movement, by getting up and move. Now, periodic leg movements, though, are the leg kicks that occur during sleep, which is different. Now, a lot of children with restless legs will have periodic leg movements, but not all of them. So it's very important to differentiate. Both conditions are linked to iron deficiency. If suspected but not clear, we can order a sleep study, and it is very important that both conditions are highly prevalent in children with ADHD. So screen all your patients with ADHD for nighttime symptoms and nighttime movement disorders, because ADHD is a 24-hour condition. When we do see in a sleep study, again, polysomnography, and this is the video, the periodic leg movements are characterized by dorsiflexion of the foot and are seen in the leg leads as this kind of artifact, this kind of signal. We have a specific criteria also to identify this and name the periodicity. Sleep-related rhythmic movements, on the other hand, are different. It's body rocking, head rolling, head banging, and these are very common and typically in young children, even starting at 9 months, and usually resolve spontaneously by 5 years of age. Commonly familiar. I actually had a set of triplets that had body rocking together, and it was really cute. And one by one, they started growing out of it by age 5. Reassurance and prevention of injuries is what is important. And in this case, although I don't have a video, but this child is moving back and forth, and we see the movement on the sleep study. Insomnia in children, it's most likely in small children, the reason that we see patients for insomnia is behavioral, and it's either limit setting or sleep association insomnia. Commonly, a primary care doctor refer patients for insomnia, and it's a lot of times it's a combination of inadequate sleep hygiene, or is seen in combination with another disorder like neurodevelopmental disorders or depression or anxiety. It is very important that it's very, very high prevalent in children with autism spectrum. I'm not going to talk about this today, but the one data that we do have in children with autism spectrum is that they do have a dysregulation of melatonin secretion, so these children do respond really well to melatonin supplementation. Refer when behavioral interventions are not successful after 3 months. I am so convinced in situations of sleep onset association and limit setting that the behavioral interventions work that I never give follow-up appointments to these patients. In my mind, giving them a follow-up appointment is almost setting them up for failure, like allowing them to fail. It's not going to fail. You do this, it's going to work. So this is very, very rewarding when the parents are invested. Very, very frustrated when the patients are, or the parents are not. But most of the time, if you really explain to the parents what their sleep associations are or the limit setting and provide them positive routines, then they will be successful. There is no gender prevalence of behavioral insomnia. I never diagnosed any child of behavioral or insomnia until the month of 6 months, and I was commenting earlier with someone that we do have a few number of parents that at 3 months or 2 months they want their babies to sleep through the night, and that is really unrealistic. It takes about 6 months for the circadian clock of that infant to get trained for the melatonin production to be adequate. So no diagnosis after 6 months is just part of being an infant. Now the one thing that we can do before 6 months is we can prevent associations. For example, do not let the infant fall asleep while breastfeeding, because you will create an association with breastfeeding. Do not let the infant fall asleep while walking, or you will create an association with rocking, and then we will have to get the child out of that association. So whatever the child falls asleep with, that's the child will have an association falling asleep with, and while they wake up to the night, they will require that. They will need to be breastfed to go back to sleep. They will require to get rocked to fall asleep. I've had situations in parents that are so dramatic that the family has actually bought like this kind of bouncy thingies that they hang from the roof, and the nanny or someone has to actually sit on it and bounce the child up and down. And when did that association get to that level? I don't know, but prevent those associations. The best scenario is the child lays in the crib to sleep. In the alone, initially with a parent there for safety and comfort, but not with much intervention. Oh. Hypersomnia. Majority of patients that I get referrals for hypersomnia are not sleeping enough. So ask the patients how much are they sleeping. This is very challenging for teenagers. But most of the time they're sleeping 7 hours, even 6 hours, even 7.5 hours. For teenagers, they need to sleep at least 9 hours. So most of the causes of excessive sleepiness during the day is not getting enough sleep. But it is very important not to miss narcolepsy, which often presents starting at 9, 8 years of age. So one of the things that make me suspect of narcolepsy is usually a really dramatic sleepiness that is out of proportion. The diagnostic criteria says it has to be at 3 months. The patients that I have really strikingly sleepiness is, well, the child fell asleep on their birthday party. That's not normal. The child fell asleep during a soccer game or watching a football game. That's not normal. So those are things that really caught my attention. We diagnosed a medical student who actually had to have his books open over an ironing board with the iron turned on, or else he would fall asleep. So this kind of degree of sleepiness. Falling asleep on my lecture could be normal. Falling asleep in school could be okay, acceptable, understandable. But falling asleep in this really outstanding, dramatic situations. Cataplexy, pathognomonic. If the child has some weakness under strong emotions, it's pathognomonic of narcolepsy. And the key in children is that it is not as in adults as we imagine cataplexy. They don't drop to the floor. They usually can't hold the pen, or they start having slurred speech. And please be sure that they are not like from another country and they're speaking like an accent with me before diagnosing cataplexy. But it is slurred speech. It has weakness of the face. The parents say the face becomes asymmetric, so it's very subtle in children. And we order a multiple sleep latency test. So, this is my last slide, but it's very important to know what has done in the past. How long have they tried? Did it work? What factors contribute to failure? Because often we have behavioral insomnia of childhood that we treat and it fails. But then what happened? The child gets hospitalized, the lights mess up their circadian clock, and then the parent comes and says to you, well, the sleep doctor recommended this, it didn't work. Well, it worked. It is just that other situations occur and contribute. Children are going to relapse really often. Every time that they're sick, the parents will have to sleep with them, to watch over them. That creates a new association. So children will relapse. Giving the parents this information really helps. This is going to work, but in 6 months it can relapse again and go back to square zero, repeat again the same steps. New medications, it was working, he wasn't sleepwalking anymore, and then started an antihistamine medication, and it all happened again. So this is very important. Weight gain. The child did stop snoring after tonsillectomy, but now he's in the 97th percentile in weight, so now things have changed. And also very important to know what is the parent's goal for the visit, because sometimes we do not match, and we need to find a common ground. What is really the parent's goal? Often the parent's goal is a letter for school, and then we have to just address that as well, because we're treating the family. But it's very important to know what's the whole family's goal for the visit. In conclusion, we have common sleep disorders in the whole spectrum and can vary from any of the ones that we mentioned. The parental concerns are wide as well, and it's very important to know what's the goals for the visit. There are a lot of populations that are higher risk, and we need to identify them with a personalized history and physical for each child in particular, and know when to order the appropriate tests. I hope to have a couple of minutes for questions. Thank you.
is what strategies do you have to promote compliance of the patients that have developmental delay, like Down syndrome, autistic kids, that we need to commit them to CPAP or BiPAP, and the parents are very frustrated and we don't have anything else to offer except of tracheostomy that they're not really very up to.
Great question. So I just gave a talk on CPAP, on pediatric CPAP, actually in Uruguay. And one of the publications that I'll be happy to share with you or with the committee to distribute was compliance of CPAP in children of various backgrounds and conditions. And there were two populations that were the most compliant, two. One of them was neurodevelopmental, and the other one was girls. So don't dismay. It is very common perception to say that the neurodevelopmentally developed children will not be compliant. So the one thing that I do tell parents is to have a realistic expectation. And the realistic expectation is that it's going to take time, that it's going to take effort, and it's going to take consistency. So consistency is include the CPAP in the bedtime routine only. Don't have them practice during the day because then the child associates the CPAP with the bedtime routine. Always use nasal masks in children because of the risk of aspiration and everything else. And sometimes, in some, like when you say you have to go to tracheostomy, well, if I am contemplating tracheostomy, the step that I do before tracheostomy is to have a night nurse. So the night nurse will put the CPAP mask continuously through the night until the child gets used to. The one thing that always works with children and works as they always work is bribery. So we have methods of positive reinforcement, and we have CPAP ferries, sticker charts, CPAP prices, and we had a child, as a matter of fact, the child in the photo with Crowder Willie, the parents actually, we had months and months, the child needed to be compliant with the CPAP and wasn't, and she needed to have growth hormone. And the parents asked her simply like that, what do you want? I want a tricycle. Okay, use your CPAP. And that night started happening. So don't underestimate the power of bribery. In other children, severe Down syndrome, severe autism spectrum, consistency is the key. Every night, slowly, don't give up. I've had to wait with children up to a year sometimes to get used to it. But when they get used to it, it's worth it. Because then they're used to it for life. So.
I have patients that have nurses and they fall asleep. So they don't even call the kids. They fall asleep. The insurance companies, they don't want to pay for nurses. I'm dealing with Down syndrome patients that already have an appendectomy, tonsillectomy, reduction of everything imaginable. The patients are not tolerating their disease. They have pulmonary hypertension. Parents very frustrated. We are very frustrated.
Very challenging. Very challenging. I have admitted a couple of those patients, and that again is very dependent specific. In UC7 California, we had a lot of freedom for admission, and we admitted the patients to have the same repeated position and placement. And I must say, there are certain, well, in those situations with pulmonary hypertension and everything, it may be worth admitting and admitting for a few days for compliance. And yeah, it is challenging, very frustrating. But don't give up because the consistency and time is the best thing. And I guess we don't have the answer all as a team. We still all battle for that. Any other questions? All right. Thank you.
I have to say, wow. I thought I know how to give lecture, but you blow my mind. Really great. Great. Thank you. Thank you very much. It was very wonderfully given lecture. Now I am going to invite one of the very renowned physician and extremely good lecturers, and he is Dr. Kanar Ramor. He all the way came from the Mayo Clinic. He is associate professor of Mayo Clinic, as well as his greatest a gift that I have looked at his resume. Almost everyone considered him as the best professor and lecturer. He is also the director of the American Academy of Sleep Medicine and Mayo Clinic. Please welcome Dr. Rahman.
Good afternoon, everyone. Thank you all for being here. It's always tough on a beautiful day like this to be sitting in this room, so thank you for still sticking around. Again, a big thanks to the organizers, the chairs of the committee for inviting me here. And I think more than me, I think my family is thanking you because we left Minnesota when it was 7 degrees, and so that's almost a 75 to 80 degree difference here. And in fact, we had some snow last night, and I think when we get back home tomorrow, it's likely that I'm going to need to clean the driveway and the car before I can take it from the airport back home. So I'm going to try to enjoy this evening and tomorrow morning a little bit before I head back. So again, thank you for being here. My talk for today is on cardiovascular disorders. This is a pretty vast topic to cover in 1 hour. I'm going to try my best to condense the talk a little bit more. And in fact, if you look at your booklet, the number of slides are around, I think, 120. I cut it down even further for my talk here. So at least you have that as a reference if you need to go back and take a look at it. And if there are areas that I'm not covering, I'm happy to stay back and answer any questions that you might have related to that. Okay. No financial disclosures. So these are the areas that I'm planning to cover in the next 50 minutes or so. Talk about the cardiovascular homeostasis and normal sleep. Talk about sleep duration and death, and in terms of how it's related to cardiovascular disorder as well. Talk about obstructive sleep apnea and its consequences related to CV disorders, and then simple sleep apnea. So I'll start off with the cardiovascular homeostasis. This is something that you may all know, and I'll give you a little bit of a rationale behind how the American Academy of Sleep Medicine came up with a definition of bradycardia while asleep. And as you can see out here, the definition is based on the heartbeat of less than 40 beats per minute while sleeping, and sinus tachycardia while asleep is going to be more than 90 beats per minute. And as you all know, this is different than the current definition. While you're awake, it's 60 beats for sinus bradycardia and more than 100 beats for sinus tachycardia. And I think you also know that this is all based on a single lead EKG or ECG that we have on our PSG fragment. And the reason why the heart rate tends to dip down while one is sleeping is because of predominant parasympathetic tone and the withdrawal of sympathetic at the same time. And I'll touch upon this a little bit more in terms of when does the parasympathetic predominance happen and when do we have more of a sympathetic surge that tends to occur during sleep. And the lowest heart rate, because of the parasympathetic predominance, tends to happen during non-REM sleep. And again, this should all be sinus bradycardia. Anything different than that may be actually abnormal. And this is based on the Sleep Heart Health study, where they looked at more than 2,000 patients, more so females than males, with a mean age, as you can see, around 62 years, with none of them being on any cardiac-active medications and none of them having sleep disordered breathing. And when they looked at the minimum normative data with plus or minus 2 standard deviations, men had a heart rate of around 43 beats per minute, plus or minus 2, and women 47.5 beats per minute. And that's where the cutoff of 40 beats per minute came for sinus bradycardia, to be called as less than 40 beats per minute, to be called as sinus bradycardia while one is sleeping. And for sinus tachycardia, of course, while you're awake, it's more than 100 beats per minute, even though some have advocated from the ACC, American College of Cardiology, to have it even lower than the cutoff being at 90 beats per minute. But however, it still, I think, still stands at 100 beats per minute, while sinus tachycardia while asleep, for the scoring, it's going to be more than 90 beats per minute. And this is again based on the sleep heart health study, where the upper limit of normal was, as you can see, for men was around 80.8 beats per minute, and women was 84.7. And if you include the standard deviation, that's how the American AASM came up with a cutoff of 90 beats per minute. And this is a hypnogram that you've seen for the last 2 days here, where the only reason I put this out here is to illustrate that the non-REM sleep occupies about 75% of the total sleep time in normal healthy adults, while REM occupies about 25%. And the reason for knowing that is because non-REM, there's a predominant parasympathetic tone. And at the same time, when you have increased parasympathetic tone, there's withdrawal of sympathetic tone at the same time as well. And so it's a quiescence period actually for the heart in terms of cardiovascular stability, and also along with it you do have bradycardia too. And because blood pressure, by the way, is cardiac output times your systemic vascular resistance, and cardiac output is stroke volume times heart rate. So when your heart rate tends to drop, there is a drop in your cardiac output and a little bit drop in your systemic vascular resistance, and a combination of both leads to a drop in your blood pressure. And the reason why that's important is because we are all should be actually, hopefully, normal dippers, where while asleep, our mean arterial pressure, as you can see out here, while awake is a little high, but as you fall asleep, it should start dipping down. And this is the normal dipping phenomenon that we should all be having because of our increased parasympathetic tone that happens during 75% of our non-REM sleep. And when you don't have that, so when you have a little higher blood pressure while asleep compared to the normal dipping phenomenon, then that's abnormal. And they are called the non-dippers. The ones who don't dip are the non-dippers. And the reason why that's pretty important and significant is because it's implicated in various cardiovascular disorders. The risk for heart disease, including CVA, stroke, daytime hypertension, drug-resistant hypertension, where defined as more than 3 drugs to control blood pressure, congestive heart failure, and there's also increased, studies have shown increased risk of mortality in people who are non-dippers. So when you see this, where the first sign in some of these patients might be that the blood pressure is a little high during, at least compared to normal, even though you may not necessarily be high, even if you don't see the normal dip that tends to happen, that might be the first indicator that there could be an increased risk for cardiovascular events in the near future. This is a study from the Dutch study looking at certain outcome measures, and they looked at more than 5,000 patients. Here you can see on the x-axis you have the systolic and the diastolic blood pressure out here, and on the y-axis you can see various factors that are being looked at. And this is just to show you that the strongest predictor for a fibrous cardiovascular death was actually the nighttime blood pressure compared to 24-hour or daytime or even blood pressure that's measured in the clinic. So if you see that lack of normal dip at night in terms of your blood pressure, then that might be a big risk factor for subsequent cardiovascular issues. REM sleep, on the other hand, which occupies around 25% of our total sleep time, is a stage of complete autonomic instability. And the reason for that is because you have increased surges in sympathetic tone. In fact, it's also interspersed with increased vagal tone that tends to happen, particularly during your tonic phase of REM sleep. So we have the tonic and phasic REM. So when you have phasic REM, with those eye twitches that tend to happen, you're more likely to have more sympathetic drive. The tonic phase might be a little bit more of your vagal tone that tends to predominate. And when you have usually between the transition between your phasic and tonic, or tonic to phasic, is where you might have an increased surge of vagal tone that can subsequently cause sinus pauses. And I'll just show you an example of that here in a second. And because of these sympathetic surges, you also tend to have variability of your heart rate, more so in the tachycardic than the bradycardic area, and also big changes in your breathing rhythm abnormalities because the brainstem, which is where your cardiovascular circadian systems is also located, tends to lead to some apneic episodes, which we probably all noticed during our PSG scoring. And that's all because of what tends to happen around the brainstem area. So this is a study that was done by Dr. Baron Somers at Mayo Clinic, but this study was done when he was at University of Iowa, where he placed a microelectrode in the peroneal nerve of normal healthy subjects, so that you could look to see what happens to the sympathetic discharges at the peroneal nerve area in these normal subjects. So while awake, as you can see, is listed out here. Oops, sorry. I'm just having a sympathetic discharge here too, so. Okay. So this is while awake here, and then this is of course in 1995 we had stage N1, N2, N3, and 4 and REM sleep, or sorry, stage 1, 2, 3, and 4 followed by REM sleep. And here, in each of those you can see that there is blood pressure and heart rate, along with a channel, along with the column for sympathetic activity. And as you can see, as one goes from wakefulness to stage 2, 3, and 4, the sympathetic discharge activity decreases significantly and almost becomes nil in stage 4. While along with it, you see a drop in your heart rate and your blood pressure. While in REM sleep, you can see surges of sympathetic activity leading to fluctuations in your heart rate as well as in your blood pressure. And this is again in normal subjects. And this is an illustrative example of what he ended up finding, because if you look at your heart rate and blood pressure, it tends to fall as you're falling asleep, particularly as you're getting into the deeper stages of sleep. And in REM sleep, you can see an increased surge in both your heart rate and blood pressure, and that seems to be predominantly related to an increased activity of the sympathetic nervous system. And this is an example of a case